focus traditionally in Parkinson's has been on motor disease. And actually, non-motor symptoms can often provide problems for quality of life much more than the movement issues. And it's really to be aware of these symptoms so that yourselves in consultations can ensure that you're recognizing these symptoms as part of the Parkinson's syndrome so that they can be kind of looked at and looked after. So, what is the definition of Parkinson's disease? We've heard about some of them, and to James Parkinson, he described Parkinson's for the first time. But I think the best definition that I've seen of Parkinson's is that it's a chronic and progressive condition which is neurodegenerative, but it has effects on not just motor, but also the autonomic nervous system, which is responsible for keeping you upright and various other things. Your cognitive processing, so Emily was referring to that cognitive processing before, but also the emotional function. And we've heard about anxiety being a symptom and apathy and that kind of thing. So it's all involved with the Parkinson's syndrome. And we know that it's all about dopamine, okay? And it's the loss of dopaminergic neurons in the substantia nigra of the brain that give rise to some of the symptoms that are experienced. And oftentimes at diagnosis of motor Parkinson's disease, people have lost 80% of their dopamine within their brain. The thing is that a diagnosis of Parkinson's is quite challenging sometimes, with people having symptoms for 4, 5, 7, 10, 20 years in retrospect before they're diagnosed. There is no biomarker at the moment, but people are working very hard to try to find one, and we don't have any confirmatory tests that actually say, yes, you definitely have Parkinson's. It has to be a clinical judgment which is backed up then by sometimes by things like DAT scans and that kind of thing, but none of them will actually say for sure whether you have it or not. So just talking about the motor symptoms of Parkinson's that people recognise, they're the things we can see. So when you walk into a consultation room, the clinician that's looking at you will be able to see how you're getting on from a motor point of view just by watching you walk from the waiting room into the office, if you like. Because we'll be able to see tremor, okay? We'll be able to see slowness of movement. We'll be able to see stiffness, and we'll be able to see balance issues. And they'll be quite easily noticed by the clinician who's checking up on things. What we can't see are the non-motor features, which may be having just as big an impact, but actually they're not easy to see for the consultation. So we have to, as clinicians, we have to ask the questions about them and screen for them so that we can help you to manage them. But we won't be able to see them when you walk in from the waiting room. Now, we know that Parkinson's probably begins in actuality about 20 years before the actual diagnosis is made. And oftentimes, retrospectively, people can talk about various symptoms that they've noticed. Things like loss of sense of smell. That's a very common premotor symptom. Sleep disturbance, what's called REM sleep disturbance, where people act out their dreams. People who do that have a very high likelihood of then going on to develop Parkinson's. People with a low mood or anxiety symptoms often then, retrospectively at diagnosis, have developed that in the years preceding their diagnosis. And constipation is very, very common as well. So the non-motor symptoms of Parkinson's, so those that aren't affecting movement but are affecting other things, are very common. And they're seldom recognised, or they're not often recognised as being part of the Parkinson's syndrome. And that goes for the patient not recognising it, the carers not recognising it, but also the physicians not necessarily recognising it. So the GP might not necessarily make the link that this is actually part of the Parkinson's syndrome. And these symptoms very often predate the movement issues. Now, 60% of patients have more than one of these symptoms, and 25% have more than 4. And actually, you look at 2 or 3 people have about 10 when you look at the non-motor questionnaire. These symptoms can present to general practitioners and other physicians as primary complaints. So somebody can go in saying that they've got a skin complaint, for example, which will be treated, but they might not recognise it as being part of Parkinson's. And And these symptoms, and I'll come on to the wide variety of symptoms of non-motor, can often cause more distress to patients and their carers than the motor symptoms themselves. So they're really important that we get on top of them. So that's a really busy slide. That's just to show you the wide variety of non-motor symptoms that are present in Parkinson's. And I'll just walk you through a few of them. So we can see constipation at the top. Constipation affects 90% of people with Parkinson's disease, with a slow gut transit, with everything that comes with that, and I'll come on to that. People have blood pressure changes, which make them sometimes dizzy or have a headache or that kind of thing. And bladder dysfunction is quite common with people with overactive bladders. Anxiety, we heard from the gentleman over here, is present in about 40% of people, along with apathy. So people's zip has been zapped, their get up and go has got up and gone, that kind of thing. And depression is very, very common in Parkinson's, but it isn't diagnosed enough, and so medications aren't then used to help. Skin problems like seborrheic dermatitis and excessive sweating is common in Parkinson's. People having difficulty that we've heard with the way that their memory is working, their executive function isn't quite as good. Sleep disturbance, being more sleepy in the day than you used to be. Sexual dysfunction, changes with vision, not being able to smell as well as you used to be able to. Sometimes pain, fatigue. So all of these things can comprise the Parkinson's syndrome, but unless it's recognised and asked about, then the physicians won't be able to necessarily do anything about it. But non-motor symptoms is an area of burgeoning research. We have little data and research about how we can treat these symptoms, and they're therapeutically quite challenging. And one of the reasons for that is some of the medications that we give to treat motor Parkinson's can make the non-motor symptoms worse. They can make you more dizzy, they can make you hallucinate, they can do different things that can worsen that non-motor burden. So it's a constant balance that we need to strike. So just coming on to a few symptoms that are important to notice that are part of Parkinson's that we need to get right, because otherwise they can really lead to poor quality of life unnecessarily. Constipation is really, really important. 90% of people have constipation who have Parkinson's disease. And that increased transit time through the gut can lead to very erratic absorption of medications. And if that happens, it can be very uncertain about when those medications are being given. So actually you get an erratic absorption of your medication through the day, whereas if you had a normally operating gut, it might work better. If you've got a very loaded bowel, full of poo, if you like, then that can push on your bladder neck, and that can cause urinary dysfunction as well. So you get a sort of a double whammy. It can also cause, if you've ever been constipated, it causes abdominal discomfort, it causes bloating, it causes nausea. It just makes you feel not very well. And you've got that to cope with as well. So having a regular bowel habit, soft stool every day or every other day, pays dividends for managing the Parkinson's. And what I recommend is that people shouldn't wait till they get constipated to treat it. Wait 3 or 4 days and then treat it with laxative. They should be on a little bit of laxative every day just to allow that soft stool to happen. And that allows things just to be managed. Some people take a lot of laxatives to achieve that, and some people don't take any. And most people are in the middle. Postural changes in blood pressure are really, really important as well, but it can be quite subtle. And if you have a big change in your blood pressure when you go from lying to standing, you might pass out. But very rarely is that the case. It's normally a spectrum of somewhere in between. When your blood pressure falls and the perfusion of blood to your brain reduces, you can get a variety of symptoms. So, for example, headache when you do that. Or coat hanger ache, so having aching in your neck muscles and your shoulder muscles, that can be something that people experience quite subtly, typically when they're standing for prolonged periods, doing the washing up at the sink, that kind of thing. People may experience lightheadedness or dizziness. They may also notice that they're not thinking as clearly. They may be a bit more cognitively numb, and it's difficult, like a muzzy head that they can't quite see through, a fog, that kind of thing. It's typically worse after eating, because when you've eaten, the blood's being diverted to your stomach and your intestine away from your brain. So that sort of exacerbates the whole thing. So we need to be vigilant for these symptoms, but more in clinic, need to be making sure that there isn't a drop. We always do a lying blood pressure and then a standing blood pressure at 3 minutes. Okay, and that enables us to see whether there's that drop, and then we can do something about it. Because remember, those medications like levodopa and ropinirole and pramipexole and rotigotine could all make this situation worse, so we have to balance it. How do we treat it? It's really important to be well hydrated, and we know that Parkinson's patients, they have less good hydration than age-matched controls. So other people who are of a similar age, they tend to drink less. So plenty of fluid. Also, increasing salt intake and caffeine intake, if this is a problem, is a good idea. Now, you won't often get doctors recommending that you eat salty crisps and you drink Coca-Cola, but if you've got a really low blood pressure, you're at risk of falling, we want to get that blood pressure up. Otherwise, you'll be at risk of falling and fracturing. And then if that's not working, and compression hosiery as well can also help the blood go back to the brain, we can start to use medications. But we like to do the easier things first before we reach for the prescription pad. Drooling of saliva is something that also causes people distress. And it's not because you're making too much saliva, it's because you're not swallowing as adequately as you used to. So you're swallowing less. And so therefore, if you're concentrating and you're bent forward, you're not swallowing, so the saliva is coming out the path of least resistance, down your chin. Normal individuals produce up to 1.5 litres of saliva a day, which is quite a lot of saliva. And if you're not swallowing it adequately, then that can give rise to issues. But we need saliva for good oral health. So if we dry it up completely, then we have another problem that emerges, and people having a very dry mouth is not good either. So we need to be trying to manage things. So making sure that the Parkinson's medications are given on time and are causing a continuous stimulation, and make sure that the off state is not being achieved a lot, means that people are on and they can swallow more effectively. We need to also look at what people are eating. So if they're eating lots of high sugar foods, that can cause more saliva to be produced. But in some way, about half of the patients with Parkinson's do have a degree of drooling, either at night or during the day. It seems to be more common in men, but nobody can really explain why that is. It can often be associated with a runny nose, and it sometimes can disturb sleep if it's happening more severely. So what can we do to treat drooling? Well, there's lots of things that can be done very, very simply. One of them is sucking sweets or ice cubes, or improving posture and remembering about posture and reminding yourself about posture and the fact that you have to swallow. And sometimes the speech and language therapists use vibrating brooches and that kind of thing to remind you to have a swallow and think about posture. Having frequent drinks, staying well hydrated, chewing gum, those types of things can also help. And seeing a speech and language therapist to think about lip seal, to think about where your tongue is and that kind of thing can often help too. And then we get to medical interventions, where we can use tablet sprays or patches to be able to dry the saliva up to a degree. But they sometimes can have side effects, so clearly we want to try to stay away from the medicines before we've explored all the other things. And if we can't use medicines, we sometimes use Botox. So Botox that people use for wrinkles can be very, very effective given directly into a salivary gland. It needs to be done every 3 months or so, but it can really, really work to decrease drooling. I've mentioned depression, and depression is something that we need to be vigilant for because it can really affect people's quality of life, and not just the quality of life of the patient, but also the quality of life of the carer. And so it's something that we really need to be vigilant for, and if it is present, we need to treat it to improve quality of life for both. If depression continues undiagnosed, it can really adversely affect people's motor symptoms. It can affect their cognition because they don't think clearly, and then that has an effect on quality of life. It's frequently underreported in Parkinson's disease. We know that. So we ask questions specifically of our patients to see whether there are any telltale signs, and often ask the carers as well what they've noticed. But people generally sometimes can wake early in the morning and not be able to get back to sleep, be more pessimistic than normal or more irrational about things or getting worried about things that they wouldn't normally be worried about. And we use our psychology input in clinic to try to help those patients, but also use medications such as antidepressants to work synergistically with the other medications. Apathy is something that affects quite a lot of patients. As I say, people's get up and goes, got up and gone. And that can affect people. And it's typically the lack of interest in things that they normally used to find interesting. Their lack of drive to do something, to initiate activity. And also a perceived lack of emotion, which can then have an impact upon intimacy and relationships with their loved ones. And it's important to recognise this because it can respond very well to antidepressants, but also recognising it and breaking a cycle and increasing physical and mental stimulation will then help the apathy cycle be broken. Urinary issues cause a lot of problems for some people, and it's typically urgency and frequency of urine. So when you've got to go, you've just got to go, and you need to know where the toilets are, and that can really affect people's confidence in going out. So it's really important for us to ask those questions to find out whether it is an issue and then do something about it. Oftentimes people can get up multiple times at night, which then affects their, the quality of their sleep, which then affects how they are the next day, and you get into an ever-decreasing circle. So if you can break that cycle by treating the urinary symptoms, people feel a lot better, they sleep better, and then they are better motorically the next day. And it can be a cause of falls at night because people's mobility with decreased sensory inputs at night, because it's dark, are more at risk of falling. If you're getting up a lot at night, you're more at risk of falling. So we need to do proper assessments, and that's often urodynamic assessments that can be done. Importantly, patients say to me, well, in order to avoid going to the toilet, I just drink less. It is the worst thing possible to do. Because actually, if you think about what that does, it creates a very concentrated urine, which then leads to irritation of the bladder lining, which means that you become more urgent and frequent. So actually being well hydrated, while it doesn't sound like it should be, it actually helps the situation and decreases the risk of urinary tract infections. There are lots and lots of medications which can be used successfully to treat urinary tract overactivity. And oftentimes people respond very well to these. So it's very important to raise this as an issue if it is. I've talked about sleep disturbance and the fact that REM sleep disturbance is oftentimes a precursor to Parkinson's disease. Quite a lot of people have active dreaming before they're diagnosed. This can be very distressing for the bed partner if people are sort of lashing out at night or doing that kind of thing. So it's important, again, to recognise these symptoms because they are quite easily treated in most cases. And again, poor and fragmented sleep leads to much worse function the next day, and it responds very favourably to treatment. Quite a lot of people have excessive daytime sleepiness, and this can be multifactorial. It can be because they're not sleeping well at night, but it can also go with the Parkinson's syndrome itself, because of neurodegeneration affecting not just dopamine, but lots of other neurotransmitters in the brain. And this can also predate the diagnosis, so people feeling more sleepy before they're actually diagnosed with Parkinson's. And again, this impacts greatly on quality of life, because if people are very, very sleepy, they interact less socially. Also has a big impact on driving and independence. If people are feeling sleepy, they become less safe to drive. And also a very important symptom called sudden onset of sleep can be seen with people just falling asleep instantly with the dopamine agonist medications like ropinirole and pramipexole. And we need to pick that up because clearly that has big risks to patients if they are one of the people who are going to suffer with that. The other thing before I come to a close that I just wanted to talk about is non-motor wearing off. And you may be aware of motor wearing off when so when you're on, you're feeling at your best with the least Parkinson's symptoms, and when you're off, you have your most Parkinson's symptoms. As you wear off, that's when you start to get more tremor or you become slower or that kind of thing. That's your motor wearing off. But this also is true for non-motor symptoms. So as people come up towards their next dose, they can feel more tired, they can feel panicky, they can get some pain, sort of non-specific pain, they can feel more anxious, and they can have some mood changes. Sometimes people can, just burst out crying for no reason. And that's sometimes indicative of a drop in dopamine levels. So if we're noticing that, we can then make medication changes so that that doesn't happen. But people don't often recognise this as being a phenomenon. Unless we recognise it, we won't be able to act upon it. So how do we manage non-motor symptoms in clinic? Well, really, it's about all of us being vigilant for them. So me, asking the right questions, but people actually saying, well, look, I've got a problem with this, and recognising it as actually being part of the Parkinson's syndrome itself and not just something else because of getting older or something that people often think some symptoms are. Making adequate time for discussion of these symptoms in outpatients. I always try to make time to go through these symptoms that are bothering the patient worse. So the top 3 symptoms, what are they and how can we benefit you? And also reiterating that medications need to be given exactly on time to ensure that there's not these big dips that occur through late medications. So just in summary then, Parkinson's is not just a movement disorder, it's a multi-system thing affecting lots and lots of different systems in the body. And because of that, their non-motor symptoms are quite diverse, they're multiple, and they're common all the way through the disease process, but they do get more common as Parkinson's progresses. And also to remember that some of the medications that are given to promote movement can also make some of these symptoms worse. So we have to achieve a balance. Non-motor symptoms are often poorly recognised by healthcare professionals as being part of Parkinson's. So we need to be constantly reiterating this because I know the profound effect that some of them can have on quality of life. We use screening tools sometimes in clinic so that we're picking them up more avidly. And the important thing is many of these symptoms can be very well managed if just we know about them. We need urgently more research to be done in these areas. And I'm very heartened to know that quite a lot of work is being done to find new treatments for these. And we'll see where the next few years bring us.